Hi, everyone. Gee, I feel like I've taken permanent residency in this tent. It's me again. Hi, Katie Couric. You know, there's an old axiom that goes, if you don't have your health, you don't have anything. And I think the three of us on stage realize how true that is. Tennis legend Chris Evert's life was turned upside down by cancer. First, with her younger sister, Jeannie, who died of ovarian cancer in February of 2020, and then with her own diagnosis of the same cancer less than 2 years later. Meanwhile, as some of you might know, I was diagnosed with breast cancer about 1 year ago on my wedding anniversary and on the first day of summer. My cancer was caught early when it was treatable, and after a lumpectomy and radiation, I'm doing well. The person who performed that lumpectomy has become a good friend, as is Chris, through the years, and that is Dr. Lisa Newman. She is the chief of breast surgery at New York Presbyterian Weill Cornell Medical Center. Lisa is here to help us understand not only the latest medical advancements, but also describe her work in making sure we improve healthcare access to underserved communities. So please welcome Chris and Lisa, everyone. Now, Chris, I know we're here to talk about cancer, but we did put together a little short clip of your greatest hits because why not? It's really quick, and why don't you all roll the tape so we can just remember what a fantastic player Chris was, is still playing, I'm sure, but she was one of the finest. So let's take a look. Memories.
Thank you. That's so funny. Oh my God.
What do you think when you see that, Chris? I mean,
they hit the ball a lot harder now. That's what I'm like, please don't show that.
But go ahead, brag really quickly about all the big things you've won through the years.
Go back?
No, just you know, like how many Wimbledons?
Okay. Well, I won.
Just go ahead.
I won 18 majors, and I won 156 regular tournaments.
But who's counting?
And I had the best winning percentage of male or female, 90%. That's my personal favorite. Martina and I, Navratilova, have a great rivalry. We played 80 times, and I think that was one of the best rivalries. And funny enough, she just had cancer as well. So
yeah, you know,
send her our love, but she's fine.
Good.
She's got a clean bill of health. Yeah.
Oh, good. I'm so glad to hear that because I've been worried about her, honestly.
Yeah.
And
no, she's
we've
fine.
texted a few times, but I haven't heard from her lately. So
no,
I'm
she's
so
fine.
happy to hear that.
That seems so long ago.
Yeah. Anyway, well, it's always, I mean, I remember watching you so well, and especially when you wore your ponytail with a little ribbon in it. That's how deep I was. But anyway, this panel, by the way, is called When the Personal Becomes Public. And both Chris and I have talked about our situations with the hope of helping others. So I just wanted to go back and tell people about sort of your situation. It begins with your younger sister, Jeannie, who I also remember seeing because she played tennis too. And Jeannie tragically passed away, as I mentioned, from ovarian cancer in February of 2020. I lost my sister to pancreatic cancer. So, you know, my heart went out to you, Chris, when this happened. Share a little bit about your relationship with Jeannie.
Well, Jeannie was 2 years younger than I was, and she was a heck of a tennis player. She was like top 10 in the country when she was like 15 years old, you know, and she beat the #1 player in the world, Margaret Court, and she had a really great future ahead of her. Unfortunately, she was 5'1". I'm not laughing that she's short, but in tennis, you kind of have to be taller and more powerful and this and that. But we had a great relationship. I mean, she supported me, I supported her. I don't know what more to say. We lived in the same city, so we saw each other all the time. So it was really crushing when this happened to her.
She had was diagnosed with ovarian cancer, but there were no symptoms. There was nothing, no signs early on, although perhaps in retrospect, and I think oftentimes when you have someone you love get sick, you realize, oh, yeah, he did lose weight or whatever. Looking back, there were some symptoms, right, Chris?
Well, I'll go back to the beginning because she was traveling with me to Singapore, and I was going to do some work there, and we were late to the gate, and I was kind of jogging, and I said, come on, Jeannie, and she was out of breath walking, and she was an athlete, you know, and so I said, what's wrong? And she goes, I'm out of breath. And I said, are you okay? And she goes, yeah, I just think I have an infection in my lungs. And I said, is that what the doctor told you? And she said, no, I self-diagnosed myself. You know, so I said, okay, we're going to Singapore. We get on the plane, we work out the next day. She couldn't even get on the treadmill. She was so tired. So I didn't want to scare her, but I said, okay, we're here for 3 days. And I want you to call your doctor right now. And the day you get back, I want you to go in and see him. And interesting enough, we stayed in the same room. And when I saw her change her clothes, even her body was different, you know, very puffy up here. And so I knew something was not right. So we get back, and she goes to the doctor, and basically the doctor says after many tests that she has ovarian cancer, and it was stage 4. It was stage 4. It was, you know, Jeannie was the kind of lady that cared for everybody else. Cared for her sisters, cared for her children, cared for her grandchildren. And she also, you know, didn't like confrontation. Yeah. You know, she wasn't really proactive. She would just let things happen to her. And really didn't, when she started to feel tired, I only said one time, I said, why, when this started, why didn't you go to the doctor? And she said, I don't know, but don't ask me that anymore. And I was like, shut my mouth for the rest of, you know, because you can't keep bringing it up. Why didn't you do this? You know, I just asked her that one time. So anyway, she went through 2 years of chemotherapy, and it wasn't working. She lost her hair. She got down to like 80 pounds, and it was excruciating to watch because it's an insidious kind of cancer to have, and she even did the trial. At one point, the doctor said, "This isn't working. We have to go find some trials." You know, so she went to do the trials, and there were like 2 or 3 different times that she would have to do it. And after the second time, it was too painful for her. Yeah. You know, they're just putting ports in every part of her body. They were draining her back. It had spread to her lungs, and so you know, it's. As a side note, as soon as she had ovarian cancer, she was tested for the BRCA gene. She was not BRCA positive. She was not BRCA positive, but she had, and I don't know if you mentioned this, a variant of uncertain significance. A variant of uncertain significance, which means 95% of the time it's nothing. 5% of the time it might be something. And it also means there weren't enough case studies of that one variant to classify it as cancer.
But then I know 2 years after she died, the doctors came back to you and said, actually, she did have BRCA. Wait, Lisa, how would that happen where 2 years later, Chris and the rest of her family would be told this?
Yeah. Well, you described a perfect story for these patterns called variants of uncertain significance, or VUSs. These genes, BRCA1, BRCA2, they're huge. They can have a lot of different variations in their pattern. some variants are completely normal, others are associated with as high as an 85% risk of getting breast cancer and quite high risk of getting ovarian cancer. But then some of them are patterns that we just don't know how to understand. We don't know whether or not they're associated with cancer. Those are the VUSs, and those VUSs, they're uncertain partly because of what you've described, Chris, that we haven't seen enough of them to be able to connect them statistically with cancer. So what happens is that they get reevaluated statistically every few years as more women get tested, and then the patients who've tested positive for those VUSs have to get a follow-up call notifying them whether or not it's become pathogenic or downgraded to negative.
Do you know, when the geneticist called me, she said, she explained what to do, and she said, you need to go see a doctor right away. And then she said, I have 36 more calls to make.
Really?
Yes.
How
so
compassionate.
that, no, but to tell families.
Oh, to tell family members.
The bad news.
Yeah.
That variant had turned into, the cancer.
So you ended up, I know, getting genetic testing, and you did, in fact, test positive
Yes, I did.
for the BRCA gene.
Yes, I did.
And so, first of all, what was your reaction to that, and what did you do right away?
My first reaction was, oh shit. It was a little worse than that, but but I wanted to. I just wanted to know what I had to do. I wanted to do it yesterday. So I went to Cleveland Clinic, gynecologist, and oncologist, and they said the sooner the better. My CA 125, which is, did you have to take that, the blood test?
I didn't take that, but
Okay,
my late husband, I remember.
Yeah, 125, the numbers were high. So I went right away and had a hysterectomy, and a complete hysterectomy. And I remember my doctor saying, we're going to get this before, we're going to be proactive, we're going to get this early, and you're so lucky that you found it now, and this and that. So we go in, and I have the hysterectomy, and then a couple days later, I get a message from the doctor saying, I'm shocked to say this, but you have cancer in your fallopian tubes and in your ovaries, and there's a little sprinkling in the wash that you have. And
which is stomach fluid, is that what that is?
Stomach fluid, right,
Yeah.
right, stomach fluid. And in 10 days, then I went to have the surgery where I had all of that removed and all of that tested. I mean, they took the lymph nodes. They took like 16 lymph nodes. They looked underneath organs. So if I would have had, if it had spread, because they didn't know that it had spread, because they weren't looking at this part. They were only looking at this part. The doctor said, we'll get the test back in 5 days. And that was the longest 5 days of my life, because I was going to be either stage 1 or stage 4. So that's life or death. And it was not, that was terrible. And I got the good news. Everything's out, and you have to have 6 chemos, and so I was ready to go.
But it wasn't over yet. Well, we'll talk about that in a moment, about what that meant for your chances of breast cancer.
The BRCA,
But Lisa, it's so frustrating to me that there still isn't a test for ovarian cancer.
Yeah, it is very, very frustrating. And as you mentioned, some people do believe in doing the CA125 levels, which is a blood test, a marker that has potentially been associated with ovarian cancer. But it hasn't quite panned out as being a reliable screening tool for ovarian cancer. Some people are now combining it with other blood markers and menopausal status to try to predict through an algorithm whether or not a woman is likely to get ovarian cancer. But right now, no good screening test. And the symptoms that ovarian cancer causes, because the ovaries are these 2 tiny little organs tucked way down in the pelvis, the symptoms are typically things that are signs of metastatic spread already, the bloating, the abdominal discomfort.
Which is so upsetting. I know they're working on a blood test in addition to the CA125 test. Is that promising? Do you think we're going to have a better screening device or screening method for ovarian cancer?
I sure hope so. But because it's been so frustrating to develop screening, this is one of the reasons why Marie Claire King, the investigator that first sequenced BRCA1 and the BRCA2 genes, she's a public advocate in favor of all American women getting BRCA testing when they reach age 30. And she says that if a mutation is found, a woman should complete her childbearing as quickly as possible and then have her ovaries removed for prevention.
Interesting.
And that is associated with a survival advantage.
You know, one thing I think is interesting, your doctor, Chris, said that if you had waited just 4 more months, that would have made the difference for you between stage 1 and stage 4. And in a way, Jeannie, your beloved little sister, I mean, she saved your life.
Yes, yes. She did save my life.
And now I know you have a lot of family here, and everybody's been tested for BRCA1, right? And we'll talk about genetic testing in a moment. But and by the way, after you did the genetic testing, well, you had done it earlier, so you had to figure out, because BRCA also increases your chance of breast cancer by as high as 80%, right, Lisa?
Yeah.
So then you had this other decision to make, Chris. I mean, I feel like, Jesus, you've been
Jeepers.
through hell. You know?
It's okay. It's fine. Everybody has their cross to bear. I went through, after I had those 2 surgeries and the chemo, I had to make a decision. What was I going to do with my breasts? Okay, so my doctor said, okay, so you keep your breasts, and 3 times a year you have an MRI, and you have to get it checked, and you come in for the CA25. You have like 3 different tests you have to take, but you're always worrying. Or you can have a double mastectomy, and you can get them all out, you can get them rebuilt, and c'est la vie. You're not going to have to worry about having cancer. So, and you won't have to go through chemo. If you don't get a mastectomy and you have cancer, then you have to go 6 routes of chemo again. Do you really want to do that? I said, no. I said, that's fine. So this past December, I had a double mastectomy, and so happy I did. So happy I did. So I've done it all. It was a 1.5 years, and I just get checked. I still have to get checked for the first 2 years, like every 3 months.
We'll talk about the importance of genetic screening in a moment, but one of the reasons we all wanted to do this panel is we all have things that we want to educate people about.
Right.
And
well, you had your health scare, so I'm curious to know how that has gone for you.
Yeah, so basically, and I think that I'm kind of living proof of the importance of early detection and the power of screening. So like a lot of women during the pandemic, I lost track of time. I was at my doctor's, and she said, hey, you haven't had a mammogram for over a year. You need to I think it was 1.5 years. And I said, oh, no, I just had one. What are you talking about? And I don't know, my sense of time got so screwed up. And I said, okay, yeah, I'm going to go. And I made the appointment. And I was with my producer, and I said, can you videotape this, but please keep it G-rated, because I'm going to talk to people about dense breasts, which I'll tell you a little more about later. And my breast radiologist, who Lisa knows well, Susan Drossman, who's awesome if you need one in New York City, she said, Adriana, you should turn off Katie's phone or your phone. And she then did a breast ultrasound, and she said, I don't like what I see here. So I got a biopsy that day. I was lucky, because a lot of people don't get it right away like that. And the next day she said, you have breast cancer. And so I was like, it was weird. I was very kind of calm about it. I think because I've been through so many experiences with cancer, with my late husband, Jay, who died of colon cancer, and my sister, as I mentioned, died of pancreatic. And when she said it's early, it's stage 1A, and we can treat it, and it's the good kind of cancer, as if. And so I felt much, much better as a result of that. So I got a lump. I went to see Dr. Newman, who is also fabulous. If you all need a breast surgeon in New York, she's so great. I just love her. And I had a lumpectomy, and then I had radiation. 15 rounds of radiation. And I love my radiation team. They were so fun. They played me really fun music in my earphones, and I brought them bagels on the last day of radiation. And now I'm supposed to, and I do most of the time, take aromatase inhibitors because I have estrogen. I have hormone receptor positive breast cancer, which I think most women do.
Yes.
And so sadly, I have to suppress every scintilla of estrogen I have flowing into my veins, and I really miss estrogen. Estrogen is a wonderful hormone. I mean, you young ladies, you enjoy that while it lasts. I'm just telling you, it's like a mood elevator. It's good for your skin and hair. So appreciate those periods. Anyway, so that was it, and it's a year later, and I'm doing well. And you know, like you, Chris, I wanted to be public about it, so I announced it. I waited till after my radiation was done, and then I basically wrote an essay about it in my newsletter, and it got picked up a lot of places, and I just feel very, very fortunate.
Yeah.
You know, and I think the reason I wanted to go public is I didn't realize, I've learned, you know, I think when things like this happen, whether it was Jay or Emily and now me, I go into reporter mode, and I knew about dense breasts, but I didn't know as much as I know now. And that is 45% of women who are 40 and over have dense breasts. So what dense breasts do, it makes it harder to determine if you have an abnormality or you have any kind of, you know, if you have strange cells or even a small tumor, because your dense breast tissue comes across as white on a mammogram, and so does your abnormality. And Susan Drossman says it's like looking for a snowball against a field of snow. So people with dense breasts should, well, go ahead, Lisa, why don't you, I feel like you're the doctor, explain what they should do if they have dense breasts.
But you do such a fabulous job of explaining it. This is what you do so well, and this is why you're so adored and why you've saved so many lives by telling your stories. So we would really appreciate it. But yes, you're correct. Mammographically dense breasts are relevant for two reasons. Number one, the density on the mammogram is very whitish, and it makes it difficult to identify cancer-associated densities, which can also be whitish. But it's also relevant because having dense breasts is a marker of having hyperproliferative breast tissue, and that means that the woman is at higher risk for getting breast cancer in the future. Now, until recently, it wasn't mandated that radiologists routinely report on the mammographic density to patients and to each other. But in March, the Food and Drug Administration did release a new policy that will be effective in September of 2024, where all radiologists across the country will have to report in a standardized fashion about mammographic density. So that's going to be empowering to women because they'll have more information about their future breast cancer risk, and hopefully it's going to support advocates for legislation to cover breast ultrasound, because breast ultrasound is a key adjunct to mammography to be able to see through that density and find a cancer. But fewer than half of the states in this country currently have legislation to support coverage for ultrasound.
And last year, along with Congresswoman Rosa DeLauro of Connecticut, I went down to Washington and we had a press conference to introduce the Find It Early Act. My husband makes fun of me and says, "Who do you think you are, Nancy Pelosi?" I'm like, yeah. And so basically it's a bipartisan bill that will require insurance companies to pay for screening, ultrasounds, and MRIs for all those millions of women who have dense breasts. Because right now, if you can afford it, rarely insurance pays for it. Sometimes it does. But if it doesn't, you have to pay out of pocket. And so there's so many women who can't get additional screening simply because they can't afford it, which is outrageous and unacceptable. So we're trying to get insurance companies, we're trying to mandate them to pay for screening, ultrasounds, and MRIs for all women with no copay. So hopefully that will change. And you know, Lisa was talking about the FDA. It really sucked because radiologists wouldn't tell women, and it varied from state to state. Or they'd say your mammogram is fine, but by the way, your breasts are dense. And you know, you have to be a doctor. You think, oh, my mammogram's fine. I don't know what it means if I have dense breasts. There are 4 different stages of density. You know, you can have very dense breasts, slightly dense breasts. So it's just so important to have more transparency in the healthcare system, and also a more even playing field. And I have to tell you, nobody has done more than Lisa Newman to try to address the disparities of the people who cannot afford good health care. But before we get to that, I want to just talk about genetic testing briefly, because this, I think, while my message is really screening, I think Chris's message is genetic testing, because until there's better screening for things like ovarian cancer, the best screening, as Lisa and we were all talking about, is genetic testing. So, Chris, you know, what do you say to people who say they don't want to go through genetic testing? Because I think a lot of people don't want to know.
Yeah, well, first of all, I wasn't even familiar with genetic testing at all. By the way, when I got that call saying, you know, your sister does have the BRCA, I mean, I didn't know that they kept all of her,
or that they had a tissue sample that they could test,
kept
right?
her records, and that they could test it again. So
how would they know, Lisa?
They keep the pattern.
They keep the pattern.
Yeah, but still,
it gets compared to other patients along the line.
And families. You know, the thing is that the reason why I wanted to use this as a platform was because when Jeannie died, I realized that a lot of people don't know their family history. And now when you go into a doctor's office and you're filling out a form, it's like, I mean, I don't know how you felt, but like in the last 10 years, it's like a pain in the ass to father, mother, grandparents. Like, what? What's this have to do with anything? You know, I didn't know. And
did either of your parents, by the way, have cancer? Or your grandparents?
No. We do not know where this BRCA came from. All I can say is my mom had a hysterectomy when she was 50 years old because she just had a hemorrhage. So in those days, you just took everything out, okay? So it probably would be my mom, but so, you know, I think that everybody here should know what their family history is, and then you can get genetic testing and you can jump ahead of it. You know, you can be proactive. The other thing I really wanted to get across was you have to, anytime you feel anything different in your body, go to the doctor. I mean, don't wait 3 months. Wait 3 days and go to the doctor. If you have anything, if you have blood anywhere, if you feel bloated, if something's not right, you have to be your own advocate, because these doctors aren't going to do that for you. You know, if it's not you, who is it going to be? So you got to really look at, you got to scan your body.
And Lisa, tell us, I mean, explain in kind of lay person's terms about genetic testing, because every year, it seems, almost every month, they discover more gene mutations that could put you at higher risk for a whole variety of diseases, right? But cancer in particular. So can you explain what people need to know, and where do they go for genetic testing? Does insurance cover it, you know, and all that jazz?
Yeah. So genetic testing to look for hereditary, generational, familial predisposition for breast cancer or other cancers can involve getting a blood specimen or a saliva specimen where the DNA is extracted, and we analyze it to look for the genetic patterns that each individual has. 50% of those genes come from the mom, 50% from the dad. Some of these gene patterns, as we mentioned before, can be associated with a higher risk of breast cancer, ovarian cancer, colon cancer, melanoma. So the information can really help people take care of themselves much, much better.
And it's expanded to how many mutations?
Yeah.
Like,
some people will have genetic testing looking at 91 different genes.
And where do you go, Lisa, to get it? Do you go to your, you know, internist? I mean, and how much does it cost generally?
It depends on the risk factors and the indications for getting testing. So for women that have a diagnosis of breast cancer, the American Society of Breast Surgeons actually says that we should offer genetic testing to all of those women, because sometimes you will find a mutation without a family history, and then all of that woman's relatives should consider getting tested as well. For women that want to follow a more restrictive recommendation, if you have a triple negative breast cancer, that's an indicator of higher risk for hereditary predisposition. In terms of women that don't have a personal history of breast cancer, if you have multiple relatives with breast cancer or ovarian cancer, and you have to look at the father's family and the mom's history, it can be passed along from either side of the family. If there's male breast cancer in the family, if there is bilateral breast cancer in the family, breast cancer at younger ages, those are all markers of a higher likelihood of hereditary predisposition. The United States Preventive Services Task Force also says that Ashkenazi Jewish individuals should get genetic testing for the BRCA founder mutations when they reach age 30, because there are 3 different mutations in the BRCA gene that are very highly prevalent in Ashkenazi Jewish individuals.
And it's also, correct me if I'm wrong, only 20% of people with BRCA know that they have it.
Yeah.
The BRCA
That's
gene.
probably correct.
Okay, the positive BRCA gene, only 20% of people know it. So, you know,
Yeah.
it's...
There is still a lot of fear in knowing, but there are things that we can do to take care of ourselves better when a mutation is identified. For breast cancer, we have several different ways of preventing the disease. Primary prevention involves the prevention bilateral mastectomy surgery, and we have great ways of doing breast reconstruction for the women that make that choice. But it is important to remember also that a prevention mastectomy isn't a 100% guarantee. We do still have to follow those women in the future. We have ways of preventing breast cancer in premenopausal women if they have their ovaries removed. That will actually lower breast cancer risk. And for some BRCA mutations, there's a higher risk of getting certain types of breast cancers that we can prevent with special pills, what we call chemoprevention. But the secondary prevention is what we've been talking about already, early detection of breast cancer. And for women that have hereditary susceptibility, the 3 tests that Chris mentioned, yearly mammogram, yearly ultrasound, and breast MRI, magnetic resonance.
And remember, you
imaging.
men out there, too. Prostate
Yes.
cancer, BRCA positive is prostate cancer, and it's also breast cancer.
Yeah.
And I think it's just a great tool to help you figure out like how often you need to be screened, how vigilant you need to be. I mean, I got my breast cancer screenings every year, especially after my husband died, because I was extra hyper about my health for my daughters. But, you know, my breast cancer came out of nowhere. It was completely sporadic. And I think one thing that I'd like to say, because I think it's a big misconception that gives people a false sense of security. They think, oh, no family history. But no family history is no guarantee. 80% at least of women with breast cancer are like me. I had no family history. So that doesn't protect you. And when I got genetic testing, I found that I had a slightly increased risk of friggin' colon cancer. Yeah. And I'm like, because I had the Ashkenazi Jew gene. And I was like, are you kidding me? But it actually was very important information for my daughters, because their dad died of colon cancer when he was 42. They have to start getting screened 10 years prior to his diagnosis. And now I want them to be super vigilant because I have a slightly higher risk. And I want to keep getting my colonoscopies as well, you know, which I did on national television, you know, gosh, in 2000. And, you know, so it's really important, I think, to talk about these things, to not be embarrassed, because it's life-saving information. And Chris, and I know that's one of the reasons you wanted to go public, because you wanted to make sure people knew these things.
Yeah, no, absolutely. I mean, with my sister's experience, and, you know, you talked about fear of wanting to know. And it's like, wouldn't you rather know and get it taken care of early, you know, and don't stick your head in the sand? And that's why I'm saying, look, I'm a tennis coach also, and when these kids out there, they're playing tennis, and if they have a little kink in their wrist, you know, I'm like, get off the court, put ice on it, see the trainer, because they want to keep playing, and then they're going to get wrist surgery. eventually if they
Right.
keep playing. And that's the same kind of thing I want to get across. If you feel anything different in your body, again, you're the only one that knows that. Nobody else knows that. Your doctor has 1,000 patients, okay? He's not going to tell you that. And know your family history. And this even carries over from cancer to heart disease, diabetes. I mean, it's a whole spectrum. It's not only cancer.
Well, I firmly believe that information is power,
Yeah.
right? And the more you know, the more proactive you can be. And I know that, Lisa, I also want everyone to know, because I feel like this is an opportunity, and I hope everyone goes home and they call their doctor, or they get genetic testing, or they take the steps they need to do, or listen to their bodies. But you worked with the United States Preventive Services Task Force, which is almost as bad as New York Weill Cornell Medical Center. And you got the age for mammograms reduced from 50 to 40. You helped with that, so
Wow.
thank you.
Thank you.
So
That's great. I read about that.
so people who are 40 need to go get screening mammograms, do they not?
Yeah, absolutely. Average risk women in the United States should start getting those screening mammograms at age 40. The U.S. Preventive Services Task Force used to say wait until age 50, but I was very proud to be part of the effort to get them to lower it back down to 40. Unfortunately, they still say every other year. Please get the mammograms every year. That is the schedule that saves the most lives. I do want to mention one thing, though. As much as we are very confident about the power of screening mammography, breast ultrasound, and for high-risk women, MRI as well, it is still important for people to know that those tests are not perfect. So women do need to know about the potential danger signs of breast cancer: lump in the breast, lump in the underarm, bloody nipple discharge, changes in the skin appearance of the breast. If a woman has any of those symptoms, she needs to seek medical attention promptly, even if she had a normal mammogram a week earlier, because some cancers are invisible in all of those tests.
One thing really disturbing, and I've had people come up to me and talk to me about this, and I know just from my work with Stand Up to Cancer, is that the number of breast cancer cases and colon cancer cases are rising dramatically, particularly colon cancer, but also there are a lot of young women who are being diagnosed with breast cancer. I'm sure people in this room know women who are younger than age 40. So do you know why that's happening, Lisa? And are those people just seen by the insurance company as sort of disposable?
Yeah. Well, we're partly seeing more breast cancer in young women because of the population structure, and we have more young women in the United States today, women in their 40s, than we did 30 years ago. But risk factors are also changing. So we had a very rapid rise in breast cancer incidence several decades ago, and then the incidence plummeted when we stopped using hormone replacement therapy as aggressively as we used to. But now those rates are climbing up again because obesity rates are increasing, poor lifestyle choices are increasing, such as increasing alcohol intake, fewer pregnancies, starting pregnancies later in life. All of those are risk factors.
And we don't even know
that
about the
increase breast
environmental
cancer
stuff,
risk.
like
Correct.
plastics and all those things. And then again, for colon cancer, it's still kind of a mystery. I know people talk about obesity and things like that and diet, but I don't know. There must be maybe something else going on, Lisa. I have no idea. Do you think?
I think there's a lot going on. We do need to figure it out. And I'm so proud that my colleague Ellen Davis is here. She's been spearheading a wonderful program at Weill Cornell where we are really leveraging the power of women to take care of their families and to control the health of their families with better nutrition, better medical care, and to take a more holistic approach to caring for the families and reducing cancer burden for the whole country, really.
I know that there are some exciting developments with vaccines that are going on. There's new imaging technology. And by the way, of all the, we've been shitting on AI all week because it's so terrifying. But in medicine, it's actually really, really exciting because now, when I gave my commencement address at UMass Medical School, I did some research on this. They can actually look at images on a mammogram and say, because of all the data and all the sets of mammograms that have been done previously and say they can find the people who are likely to develop breast cancer in the next 5 years. That is so amazing, isn't it?
It is.
So is that going to hopefully help reduce or bring down the number of breast cancer cases? Because with that early detection, people then can take proactive steps to prevent it, possibly?
Well, hopefully it will certainly prevent our mortality rates from breast cancer.
Right.
Earlier detection. But some cancers detected early will be associated with a lower likelihood some high-risk lesions, I should say.
Yeah.
Caught earlier can prevent the development of breast cancer if they're resected, sort of like removing polyps and preventing colon cancer. So the hope would be that we can identify these types of precursor lesions in the breast as well.
You know, I just want to tell one story about when you're talking about, you know, go out and get genetic testing. I think I remember I got one from my internist. I think it was about $900. Would that sound about right? It was the whole genetic testing of so many different things.
It can be a few hundred or it can be a few $1,000s.
Yeah. So anyway, long story short, I have my massage therapist was giving me massages during my chemotherapy, and she was telling me, she goes, oh, you know, she's 40 years old. She says, I've been spotting, and I go to the doctor. She went to the doctor, and she had some polyps, but the doctor wasn't going to do anything about it. He didn't go on and say, do something else. She kept spotting, then she got she was cramping, and I go get genetic testing. So she went to get genetic testing, and she goes, well, the good news is I don't have the positive BRCA gene. But the bad news is I have Lynch syndrome, which is the most common thing that when you go to a gynecologist. I said, what's the most common thing you see? He goes, Lynch syndrome.
That's a subset for colorectal cancer, right?
Yes, it is. And she had stage 3 uterine cancer. Okay, from spotting and from cramps. And that's an example. It's like the first sign you have something different with your body, you know, that's just, I just want to shake people, you know, go get it taken care of.
But I want to open it to questions, but I really want to point out what Lisa has done with health inequities. And I want to just read a couple things. The Washington University School of Medicine survey found that white women are almost 5 times more likely than black women to be referred for genetic counseling and testing. Black women have a 40% higher mortality rate from breast cancer than white women. So, Lisa, talk about that for a minute and what we all can do as a society to close that gap.
Well, first I have to tell a little story about you, my dear, and the wonderful impact that Katie has on the public and how she's so dedicated to public health. As this incredible woman is going under the effects of the sedation for her breast cancer surgery, what she's talking about as she's going under is how she wants to help other people who didn't have all the advantages and the options that she had in taking care of their cancer. She wants to make sure that other people can take better care of themselves and get screened. She's talking about the public as she's going under general anesthesia. Unbelievable.
Well, I couldn't stop thinking about that, honestly, as I went to New York Hospital and I had all this, the benefit, I'm sure you thought about it too, Chris, of all this modern technology and ways to figure out, you know, if they had to take out my sentinel lymph nodes and, you know, all the things that I had access to. And I just thought, what do women do, and men, if they have a health issue? And they can't go to a decent doctor. It is just
terrible,
unconscionable. So how can we change that, Lisa?
Well, when it comes to the disparities between black women and white women with breast cancer, you're right. They are very large magnitude, more than 40% higher death rates in black women from breast cancer compared to white women. For women under the age of 50, black women are twice as likely to die from breast cancer compared to white women. And this is because of a lot of reasons. Socioeconomics and barriers to accessing the healthcare system definitely play a role. And black women are less likely to get the highest quality mammograms. They're more likely to have delays in getting a cancer diagnosed. They're more likely to be diagnosed with more advanced stages of disease, and all that will factor into higher mortality rates. But there are some other issues that we really need to investigate with better research, and we're making some progress. Black women are inherently more likely to get tumors that are biologically aggressive, such as the one that we call triple-negative breast cancer. And my research team, the International Center for the Study of Breast Cancer Subtypes, we've been studying triple-negative breast cancer not only in black women and white women, but women on the continent of Africa, comparing the genetics of West African ancestry to East African ancestry. And we have actually identified some genetic markers specifically linked to West African ancestry, which is the shared ancestry that we have in African Americans because of the transatlantic slave trade. And there are specific markers of West African ancestry that developed as a consequence of needing to be resistant to diseases like malaria on the continent of Africa. But now today we see that these markers are associated with a higher risk of triple-negative breast cancer. And as we learn more about immunotherapy, we're discovering that it's increasingly important to understand those genetic markers so that we can come up with better targeted therapies for these triple-negative tumors.
And that's such an area of research that has been, hasn't been really accomplished or really attempted as much as it needs to be.
Yeah.
These physiological and genetic differences among all people, and how it may predispose them to certain cancers and really overall diseases.
Yes.
So, but especially people of color, right? I mean, they've been
Exactly.
kind of ignored. You just look at clinical trials, and there are very few people of color who participate in clinical trials.
But isn't the elephant in the room the fact that if you have great if you have great health insurance, which is money,
Yeah,
you're going
of
to get
course.
in. And we all have friends that have to wait 3 or 4 months to get in. And it's like, okay, they could die before that time. So.
Yeah, very true. And today, the typical demographic of somebody that participates in a clinical trial is an affluent, higher educated, white person with cancer. And people of color are less likely to be offered clinical trials. They're less likely to be treated in facilities where clinical trials are available. Yeah. And clinical trials represent our best way to improve cancer treatment and cancer outcomes.
But I'm glad, I do think that the medical community is paying much greater attention. I think, post George Floyd, I have to say, and Black Lives Matter, there's been a greater awareness in the medical community about disparities that exist. Good. And at least there is now an effort, Lisa, and you're doing such tremendous work in this area to level the playing field or to try to address some of these issues that are causing these inequities. You don't usually have a brilliant doctor like Lisa Newman here, and I don't think she's going to charge you if you ask her questions, which is a real, incredible athlete like Chris. We don't have a lot of time. Maybe we can go, Kitty, can we go a little over? Of course. Okay. So why don't we go ahead and ask some questions? There you go.
I'm picking you.
I have the mic.
Okay. Oh, you got the mic. Okay. I'm picking you.
And after her, you can go.
So thank you so much for this information. It's life-saving. I wanted to revisit the conversation around dense breasts because I am vigilant about getting my screenings. And for the last 10 years, that's what I've heard, that, my mammograms have come back normal and I have dense breasts. And so now you've educated me on I shouldn't have a sense of security around that. But could you speak more to what else I could be doing now that that is the diagnosis?
Yeah. If you've been told that your breasts are dense by mammograms, then absolutely make sure that you get ultrasound as a supplement to evaluating your mammographic density. And questioning the doctors, it's exactly what you're doing now. Keep doing that.
And if your doctor says you don't need an ultrasound, just find another doctor.
Yeah.
Hi. First of all, congratulations for an impressive presentation. Congratulations for your courage and for your worries and respects toward the others.
Oh,
thank you.
Thank you.
I understand that the presentation was much more based and exemplified with breast cancer. I happen to be an Ashkenazi Jew, and I'd like to understand more what I can do because I got really confused with this preventive testing because I would like to know if there's something I can go and check cancer from my toes to the top of my head, or you mentioned 91 genes, so I got a little bit confused, and I would like to know what I can do preventively. That's the reason I'm here, by the way.
Yeah, very important questions. Now, when we do panel testing, for example, in people that have a diagnosis of a cancer, that's where it can sometimes involve looking at 91 different genes and their patterns. For Ashkenazi Jews, there are 3 specific mutations in the BRCA1 and the BRCA2 gene that are linked to Ashkenazi Jewish heritage. And those are the ones that we recommend routine testing for in Ashkenazi Jews once they reach age 30. And if they do, if that Ashkenazi Jewish individual does test positive, then they will need to be careful about their monitoring for breast cancer, ovarian cancer, depending on the mutation, possibly pancreatic cancer.
Yeah.
So the mutation can definitely influence how you take care of yourself.
Well, I didn't reach 30 yet, so it's okay. But why are you laughing? Anyways, I heard about a company called Natera, and they have a test called Empower. Yeah. Is that something generic that I could do?
Yeah. That's a test that looks at, many people refer to it as a liquid biopsy, evaluating for evidence of cancer cells in the circulation. There are some studies that aren't quite ready for prime time yet, but there are some versions of liquid biopsies that look very promising as a screening for early detection of cancer. They're still in research. But some of the studies that are, the products that are commercially available, such as Signatera, are used in monitoring patients that have a cancer diagnosis to see if there's evidence of the cancer returning.
But it's
or to
not
see
really
if the
ready
treatment
as
is working.
diagnostic, as a
Not as a
diagnostic tool
diagnostic,
quite yet.
correct.
Okay, thank you. The
Thank
doctor
you.
is out now.
Very sharp
Okay,
question.
thank you. How about you, sir?
I think I have a little bit of a follow-up question. Thank you. My doctor had me take a test. It was called the Gallery test. I don't know if you're familiar with this
I think
test.
that's the one I took.
And
Gallery.
I was wondering if you are familiar, or either one of you, whether you had a comment on the effectiveness or ineffectiveness of that test. It's called the Gallery.
Is it a blood test?
It's a blood test where they check for evidence of all sorts of cancer, and it felt like their results, if they came back negative, were 50% accurate, and if they came back positive, were like 80% accurate.
Yeah. So that's another version of one of those liquid biopsy tests, and there is still a very broad range of their significance if something is identified. So they are definitely not yet ready for widespread rolling out to the general population to establish a cancer diagnosis, not for screening. But that is the hope for those types of tests, that those liquid biopsies will be able to identify a patient that has an early cancer and figure out what type of cancer.
My doctor was really trying to push it on me. He was really building it up. This is the first one that we have. And this is going to be great in the future. And that was one that cost me $900. But I felt like, you know, if it's 70, 80% accurate, you know, it's definitely not 95% accurate.
I think we have time for maybe 1 or 2 more questions. Kitty Boone.
Oh, Kitty. Love her. Gotta love that lady.
It's like 2 questions. Sorry.
Oh.
The first one is I didn't quite get the relationship between the BRCA gene and ovarian issues, because I always thought the BRCA was related to breast, but you made a connection with
Yeah.
the
It
ovarian.
increases
Both.
Yeah.
Yeah.
So that was a question. But the other thing, for those of you that are pass holders, the reason that we wanted to have this conversation is because Chris went public. Well, she was, I think, where were you doing Wimbledon last year? And you know, having grown up watching Chris play tennis and the celebrity, to be so open and honest, as Katie has always been, about a very personal diagnosis, I think was really incredible. And I've thought about this, and I think more people need to be public about who have the position of a platform, and I just wonder how we could encourage more people to do it, because I think you are saving lives. So those are my 2 questions.
Well, why don't you do the ovarian connection?
Yeah, thank you for bringing up that clarification point. Yes, mutations that are pathogenic, disease-associated in BRCA1 and BRCA2 increase the risk of breast cancer as well as ovarian cancer, and they increase the risk of male breast cancer and sometimes others. But breast and ovarian are the 2 big ones.
Yeah.
And in terms of getting more people to go public, I mean, Chris and I were talking before this panel, and I said, "Were you, anxious about talking about this?" And she's like, "Not at all." Why not?
Why are you supposed to be? Are you supposed to be ashamed? I mean, it was a no-brainer. It was a no-brainer. Get it out there and help people, right?
And the thing is, it does. I mean, they've shown, like when I had a colonoscopy on the Today Show, and I've had.
By the way,
thank you.
that's awesome. That was.
I told my producers I
impactful.
draw the line at a pap smear. But I've had 3 people come up to me at this festival and say, "You know what? You saved my life. I
great.
went and got screened. I didn't want to, but I saw you on the Today Show, or I've heard you talk about it. I saw you bring Jimmy Kimmel to get a colonoscopy, and I decided I was going to get one too. And I was diagnosed with stage 1, stage 2. And thank you. I mean, what's better than that? I feel like, if you can, what do they say? You save one life, you save the world. And it's just so gratifying. And it's almost, I think it's almost criminal if you have important, potentially life-saving information to share with people. If you don't, I sort of feel like shame on you.
How about selfish?
Shame on you.
Yeah.
Hi.
They're so spectacular.
And then we'll do 2 more, and then we'll stop, I promise, because I feel bad. Maybe 3, but go ahead. Can you do your question in the, John's like, do your question in the form of a question, please.
Yes, my question and request, whatever it is, I think I love the idea of spreading the word. Could you go on like a world tour talking about this, just like you did for tennis, and I'll host you in India. So, I mean, really, I swear, because I think we travel for entertainment things, etc. This is a very important thing, and you can really inspire a lot of people.
Well, want to go on a world cancer tour?
Do I have to pay my own way? Or can I?
We'll get a
Can I get a
sponsor.
little help?
Go ahead, yes.
Thank you.
Wondering about the mental health impact of somebody who is being monitored aggressively for breast cancer, because I feel like that's something that took me by surprise and not talked about a lot. Like you're doing all the right things. You're going to the doctor, you're getting monitored, you're doing everything. You're not at the point where you're going to get a double mastectomy, but you are in this journey every quarter of your life, and you're waiting for some kind of shoe to drop. Yeah. And so I'm wondering about the mental health aspect of living that journey. I started at 46. I'm 50 now. It's going to be my life for the rest of my life.
Do you recommend people who are having to be vigilant, Lisa, get some kind of support for some of the anxiety and worry that accompanies this kind of, charting?
Yeah, you are so correct. Thank you for bringing it up. It is an extremely stressful journey for women. Every time you go for the test, there's the concern before you go in. There's the waiting for the results. It really is very tough. So there are wonderful holistic and complementary integrative care support programs that a lot of our patients in New York find helpful. And we have some wonderful nurse practitioners that specialize in this who do Zoom-based classes teaching women about yoga therapy and meditation exercises, and a lot of women find those types of approaches to be helpful in just getting through the stress.
And also remembering that you're being proactive for your health, so be proud of yourself for that. Do you know what I mean? And I think that sometimes is overlooked as well. 2 really quick questions. Hi, I know you were waiting. Yes, you, hi.
Thank you. Can you speak about breastfeeding and nursing and potential risk or mitigation of risk and what the data show? Thank you.
Thank you. Great point, because we talked about how lifestyle issues such as obesity, sedentary lifestyle, alcohol intake when it's excessive, those can increase breast cancer risk, but nursing, lactating is a great way to lower breast cancer risk, and nursing lowers the risk of getting all types of breast cancer. It lowers triple-negative breast cancer risk, one of the biologically more aggressive patterns, and it lowers the risk of getting an estrogen receptor-positive breast cancer. So nursing is great.
And finally, the last question. Hi.
Thank you. Chloe Bird from Tufts Medical Center and RAND Corporation. And I just wanted you to speak to, given Arthur Mirren's work showing how much higher the funding is for research on diseases that predominantly affect men or exclusively affect men, the far greater likelihood they're underfunded when they're on women, and our work showing a, 95x return on investment on increasing funding for research on women. What would be possible in your work if it were fully funded? What's possible in advancing the work on cancer?
I'm developing a documentary about this, so I want to get your card before you leave.
Yeah, you raise such a great point, and these types of disparities in funding are true with gender, but it's also true with regard to disparities related to race and ethnicity. It's across the board, and we see the disparities in the funding regarding those particular types of cancers in women and in minorities, but we also see them in terms of the researcher that gets funded. Women are less likely to get funded. Researchers of color are less likely to get funded. Huge
I think we have to start speaking out about it. And I don't think people realize that women weren't included in clinical trials till 1993, and that female mice weren't used in experiments until 2016. And so I think it's a really important topic that I'm really interested in. So hopefully, if we yell about it, maybe things will change.
And this is definitely the time to yell, because the Supreme Court has just today released a decision that is going to have long-standing ramifications on the profile, the demographics of our research and medical care community in the future. And that's, I feel very
I don't think people think of affirmative action affecting healthcare, but Lisa, I know you've worked very hard to make healthcare professionals more diverse, which is so important, and this is at risk as a result of the affirmative action decision today.
Yeah, we have a long way to go in terms of improving the diversity of our clinical trial or healthcare workforce overall, and there are big chunks of society that have been systemically excluded from careers in the sciences and in healthcare, and that means that we're missing out on all the talent and creativity of that population subset.
And life experiences, right?
Life experiences, perspectives, yeah. So if we give people excuses to ignore those diverse opinions, perspectives, experiences, we're going to end up with a healthcare workforce that is even less reflective of the patient population that we care for and more disconnected from our patient population.
Do you feel like more women are fighting for this or more men?
I do like to believe that women are more passionate about the fight, and I think that's true.
Because it just seems to me like I know in tennis, like the women were always trying to fight for equal prize money, and my take on it would be, gee, it sure would help if some of these men would support us, you know, because all you hear are the women, and the men are like, ugh.
I do think that's a valid observation. Yeah.
I'm thinking the women, you know, I just hear about women really being passionate about this.
Yeah.
Well, maybe we can get men to join the fight
we
too.
gotta get
But
men.
Lisa Newman, Chris Evert, thank you.
Thank you.